So my work in acute care, and when I decided to do more work with research, was when I was working with a young mom in the acute care setting. And her baby came in because the baby wasn't gaining weight and wasn't alert. And so they were in for investigation. And what we found was when we woke the baby up, she fed. And so what we understood was because mom wasn't hearing the cues of the baby crying because of her own substance use, the baby learned to not wake up and cry. And so once we discovered this, they were discharging the baby home. And I said, aren't we going to talk to the mom? Aren't we going to ask if she's okay and if she needs some supports? And when they told me, no, that wasn't my job, I started to think there's something wrong with this. And that's what was obviously not the first, but that was kind of the final thing that made me decide I need to do more. And so, as you can see, the work that I'm doing resonates to me. And I'm hoping that I'm able to share to my best ability the experiences that the community shared with me. So in Canada, we know that, and this is obviously an underestimate, but 660,000 children under the age of 18 live in households with at least one alcoholic parent. And although many children live with people who are substance using, they do not necessarily experience neglect or abuse, but they are at increased risk. And so this drives some of the impetus for the research that we're going to talk about today. So what I'm going to, the outline that we're going to follow is we're going to look at a little bit more about the background, community engagement, and language. These are two key pieces to understand the research. Just review adverse childhood experiences. Ronnie's with us today, and she's going to share lived experience. We're going to go through the main themes and then talk about next steps following the findings. So it is deep privilege for me to be able to participate with this community, to hear their stories, to have witnessed their struggles and their courage. Early in recovery, it can be difficult to share stories. So for that purpose, I am sharing the community findings with you and how we have made meaning to what was shared by the community. There may also be community members online, and I welcome any comments during my presentation to add in things that you feel would enhance this presentation. So, how did it all start? Well, in 2017, a community engagement and knowledge exchange meeting started within the community. And many people within the community came to discuss the impact of substance use and addiction on the community. And one of the themes that came out of that discussion was that the impact on family and caregivers was a critical problem. And so Dr. Jeffrey Mena, he's an assistant professor at the College of Nursing in and living in Prince Albert with the University of Saskatchewan. He was one of the organizers of this knowledge exchange, and I was there, and we decided that we were going to try and write a grant to see if we, with the community, to see if we could get some funding to look further into this and how the community could garner some support. So we did write a grant with the community, and we were funded by the Saskatchewan Health Research Foundation and the Saskatchewan Centre for Patient-Oriented Research. And that's how this work started. And in order to do this kind of work and use community-based research, it has to, and must stem from community engagement. So with the topic from the community, we move forward to collect the data. And then once we receive the data, we presented it and looked at it with the community, got feedback, and these are the findings that I will be sharing today. So community engagement in research happens at all levels. And I'm really happy to be able to say that this research came from the community need, and therefore the community can take ownership now. The data belongs to the community as to what they would like to do with, and anybody in the community can use the data to move forward. So language matters. To have a deep discussion about this, this became a discussion at every stage of this research, because not everybody is using the same language when we're talking about substance use disorder. Did you know that international studies by the World Health Organization show that alcohol and drug use disorders are among the most stigmatized conditions? One of the findings that stemmed out of this research, and the reason I'm bringing it up now, is because we are changing the language within the presentation. And so one of the findings was that the choice of words we were using was very important. So at the community engagement meetings, some people were using stigmatizing language. And in order to break down barriers to recovery and wellness, we need to break down stigma. And many people with lived experience with substance use have shared their stories about stigma in their communities, workplaces, and homes. On an individual level, stigmatizing words or actions are harmful. Collectively and over time, they have a greater impact on people's health and well-being. So the language that we're using here is considered person-first language. And I'm certain that most of you or all of you already know how to use non-stigmatizing language. May not be labeled as person-first language, but it acknowledged someone as a person before they're describing their person attributes. So when we are talking about respectful language, we're breaking down barriers, including stigma, which is an attitude, belief, or behavior that discriminates against people. So when we're talking about substance use disorder, we're replacing substance use disorder instead of addiction, addicts, drug user. So all the time when we're looking at the data now, we'll be looking at substance use disorder. Now, we always have to be aware that it is whatever the person wants to use, the type of language. But as a healthcare professional, I'm using non-stigmatizing person-first language. So the person first, their condition second. We're not labeling the person by their condition. And as a healthcare provider, I can say that for some health conditions, it doesn't seem to be a problem, but it is, because when I'm in the emergency room and I'm talking about that gallbladder over there, it's not very person first. And so that might be one example, but with that example, there isn't a stigma attached. We know through the evidence with substance use, there is a stigma. Okay, I'm going to move forward. Adverse childhood experience. So adverse childhood experience, otherwise known as ACEs, are potentially traumatic events that occur in childhood, 0 to 17 years, such as experiencing violence, abuse, or neglect, witnessing violence in the home, having a family member attempt or die by suicide. So these were This questionnaire was developed many years ago by Dr. Vince Felitti and Kaiser Permanente, and many people have heard about it. Some people use them in their work. Some people have heard about it but don't use it. So I'm bringing this to the forefront because it is imperative to understand it when looking at the findings. Now, I'm not going to go through this infographic, but the reference is here. And we know that in high doses of stress, we can harm a child's developing brain. It leads to how they respond to stress overall in their lifetime. We can damage their immune system so profoundly that they have found that it affects their health in decades later. So some of the participants in the findings had high ACE scores just by sharing their experiences. One other thing that I did want to point out, that with looking at adverse childhood experiences, they do not take into account resiliency factors such as family support, an understanding teacher, a reliable adult in a child's years. But a child that has an ACE score of 4 or more, they are increasing developing health issues such as diabetes, heart disease, stroke, substance use. So it's important to take these into account and understand the effects that it has on the brain. So we know that this isn't just for children, it's also for adults. In short-term effect, stress can affect our attention and focus, learning and recall, short-term memory, finding words. With chronic stress, we get disrupted sleep, emotional distress, poor eating habits, and it impairs our regulation of cortisol, which actually changes the brain. It changes our amygdala, our hippocampus, and it increases the risks for diseases like Alzheimer's. So this helps to have a visual effect of the effects of stress on our bodies, especially when it's over a long period of time. All right, I'm not going to play this video because it is quite long, but Dr. Harris talks about, and this video is about 5 years old, but she talks about when she learned about ACEs and how she got so excited that everybody would want to use them, and everybody would want to use them in your daily life when you're seeing a child. So if someone came in with asthma, why is that asthma exacerbating right now? Is it related to the stress in the home? And are we asking about the stress in the home? Just like my experience on the pediatric unit, are we asking about what's going on in the home? And so she was very disheartened to learn that not everybody was excited about using ACEs as her. And then her message at the end is that it's a movement. And so I want you to think about that when I'm presenting this information, because some of you might say, you know, there's not a lot of new information here, but really there is. And so it is a movement, it's a journey. So I bring you back to what I'm presenting today. And what I'm presenting is an understanding of the experience of families and caregivers affected by substance use disorder and addiction. And we gathered this data through interviews with a family member or a relative that was directly impacted by someone with substance use disorder. So why is this important? I already talked about how many children live with someone who has or is experiencing substance use disorder. We have numerous studies that talk to us about how much money we are using in relation to substance use, the costs related to substance use. We see the rising deaths of overdose. And we cannot seem to put a number about how much money is being used to support families or not support families. So I'm here to share the families' experiences with living with people with substance use so that we can support the families so that they can support their loved ones. Now we're going to move on to the research main themes. So the main themes of the research are coming from interviews with 21 family members who identified as a primary support person. And these themes were the people that we were interviewing, the people in their life were actively using. And so although there are three areas, the impact of substance use on families, the factors that shape the family's experiences, and self-care strategies for families affected by substance use disorder and addiction. So under the impact of substance use on families, I'm going to go through 5 themes, but under these were many others. So one quote, when you have 21 interviews, there are many quotes, but we tried to put them in the general area that we thought they could fit in. And under psychological impact, this quote, "I just cried all the time because I didn't know what to do. And I would drive around all night looking for them to make sure they were alive. At the addictions counseling, she said, you need to give them tough love. And they spent 5 minutes with us, and that was all we got." So under this theme, there are many emotions that I feel. Other quotes under this, what came out was grief, grieving loss of the relationship with the family member who was using substances. But all the while during that grief, there was hope, a hope that the relationship would be restored. There were other types of loss of innocence, the innocence of a child who was needing to take care of others in their family and taking the role of a parent when the parent was using. There was a loss by parents. There was the loss by parents of their child. The time, the potential of the child that could be if they weren't using. There was a living in dread and despair and worry as to what was going to happen if I don't take care of that family member. What's going to happen when I find them, as in this quote? And there is a living in perpetual crisis with an overwhelming demand of care. So the family members are doing more roles in the home, in the family. And then there was the fear of loss of their loved one. So it's difficult to put these quotes in each theme because they all work together. The socioeconomic impact. When they would come to the house, Sorry, I have to move this. They'd stay for a little bit, but then they'd steal from us. They stole food, furniture, money, whatever they could get their hands on so they could buy that drug. They'd steal from the stores, they'd steal from whoever they could steal from. So it was common for the participants to report a material loss, a financial loss. And despite all of the energy that they expended, time, energy, and money into caring for their person that they were loving who was using substances, it wasn't helping, but the hope was there for something to be restored. Another piece was that the members felt homeless, not houseless, but homeless, because living in an environment took away the joy of having the home. And although the participants weren't without the house, like I said, there was an unease due to the conflict, the stealing, the apprehension of what was coming next. The social impact. So there was always stuff going missing from my house. Finally, I said, I'm not buying stuff anymore. I'm not buying any electronics. I'm not buying nothing because everybody's stealing it anyways. It's just so frustrating. It just puts so much stress on me that it's almost like I view coming to work as a getaway. I'm always trying to get away from my house because they've almost taken it over. And it's so stressful. Like, I can't tell you how stressful. And, you know, I'm depressed because of it. I'm stressed out because of it. It's affected my job. I stay up, you know, till 3, 4 o'clock in the morning sometimes, checking on the garage and just kicking people out. So an example of the lack of sense of security in one's home, the impact on social life, and the impact on social life on, it would be on children, on what it would be like for a child to come home and not be sure what they're coming home to. It may not be consistently this way, but it might be. And so it's the uncertainty. And so you can see that this theme can easily, move into the physical stream as well. I have a chronic illness and I've been diagnosed with fibromyalgia back in 2008. So roughly for the past 10 years, I've had this, but it seems that stress brings on an attack almost. So if I get really stressed out, if I get angry and I'm yelling at my kids, it's like the next day I'll be sick, literally physically sick. And so yes, it's affected me physically, mentally, spiritually, emotionally, in every way. So many participants felt that despite the actions and energy that they were expending were ineffective because their relatives continued to use despite their efforts, but they were left just grasping for hope, grasping for finding some help somewhere. And the care that they were giving became a full-time job due to the chronicity of substance use. And this meant taking responsibility for your loved ones' lives, including financial, parental, potentially taking care of grandchildren, necessities for life, meeting healthcare expenses. And so the long-term effect of this is where it was wearing down the caregivers and impacting their health in the process. And it impacted work-life balance, and it impacted their work because they weren't sleeping, and it impacted their desire to go home. So understanding factors that shaped the experiences, which we're going to look at next, are vital to development of self-care strategies. So factors that shape the family's experience. So what we found was that the understanding and knowledge of substance use disorder and addiction on families was key in how the families responded within and to the people in their lives. There was a general theme of lack of resources within the healthcare system. And in many ways, the professional responses, the healthcare professional responses were not sensitive to their needs. And therefore, it impacted the resource availability. So the people within the healthcare system did not encourage links to resources that could help them. And they were not sensitive to the needs of the families using substances. And family dynamics, it was interesting because there were several different family dynamics, but intergenerational substance use was complex social issue to manage, but also was the complexity by people who had not experienced a family member with substance use disorder before. So there were competing dynamics going on. So we know that every family is different, and the dynamics happening within that family impact people in a layered way. So if there was a spouse who was, or a caregiver with substance use disorder and a child, as Ronnie talked about, those shape the family differently and how they dealt with the substance use disorder. So the self-care strategies used. These are the 4 areas that we saw come through. Many people used, this is going to be double-edged because many people use self-help groups. And some people used healthcare providers, others online resources, and yet others went into a helping career so that they could help others. So as going through the training for a helping career, they learned about substance use disorder, which helped them. The caregivers were extremely resilient because time after time, they would continue to knock on people's doors to seek help. Most of the time, they were seeking help for their loved ones. But yet for self-care, the people that what they found was Al-Anon. And Al-Anon, they found, were devoid of stigma and judgments about addiction. And those are quotes. And the members could relate to, and they could learn from each other. The formal counseling that some of the people found useful were educative for both their children and for caregivers on the complexities of substance use disorder and addiction. Through counseling, the affected families were able to understand the need to focus on themselves without guilt and how to develop healthy boundaries. So what is the community asking for? The community is asking for better health supports for themselves, but mostly they were asking for more support for their families, for their loved ones. So what are some of the key findings from this research and the key steps to be taken when co-developing resources so that it can be used in community recovery and wellness, support families and community? So how we got these outcomes is that we took the findings that I just shared with you, but they were pages longer. We brought it to the larger community. Other people from other communities came, like Ronnie. And so she was part of this process. And the key things is that the community input is key. We cannot develop resources without asking the community. The language we're using is key because the language breaks down stigma, and it helps for the people to feel comfortable to talk to me about it. And one of the outcomes, the major outcome, was that the larger community needs to know how substance use disorder and addictions is affecting families. If that was the only thing that came out, that was it. That's pretty powerful, because when I grew up in rural Saskatchewan, nobody talked about the effect of substance use on families. And now when I come back to this research, the community is still saying we need to talk about the effects of substance use on families. So when we ask them, what kind of support are you looking for? Support groups for families. So despite finding out that the families that were using support groups, there were many that didn't know that there were support groups. They didn't know how to find them, and they didn't know how to get there. So that links into the information on about available resources. So information about available resources needs to be in the media. Our healthcare providers need to know how we can link the people up when we are talking to families. They want more professional help, and they want sensitivity towards working with families and those with substance use disorder. And that comes across the border. When we talked about where that will be, which I will read you a list right away, that's in the hospitals, that's in education, that's everywhere. And the resources for early identification and intervention. And the resources for early identification and intervention are twofold. It's for families that are dealing with substance use disorder, and it's for people who are living with substance use disorder. So now I'm going to just read a list of some of the quotes that the families left with us. We need increasing awareness of the existing services and support, less fragmented services, better publicity of existing services. We need to foster support groups. So if support groups are hard to find, where could they be easier to find? There are many places within the communities. We just need to open the doors so a support group can happen there. There is little cost involved. Family-oriented services, and we need to promote community connections. Promote workplace and community awareness of how addiction is affecting families to reduce stigma, trauma, and isolation. Educate families and communities about substance use disorder and its impacts, including the intergenerational impact. Address overt racism and the social determinants of health. Use non-stigmatizing language, non-biased and blaming. Increase education at the school level about the effects of substance use on families. Promote community conversations about how this is affecting our families. Healthcare providers did not recognize the stress that is imposed on family members when they're working and dealing with family members using substances. They went into concrete ideas like develop a family resource center, a peer support structure, make all of our services family-oriented and family-focused, better integrated, act on a provincial mental health strategy, more resources for shelters. So Ronnie talks about how we can change things as an individual person in our work, in our personal life. We need community support. What the community is asking, what this group of people were asking us is to create space. I believe creating space is not just a physical space, but it's a space to have the conversation. what I heard was that we need to talk about this. We need to have places to talk about it. We need to have places in our education system to talk about it, to talk about the effects of substance use disorder on our families. We need to use person-first language to talk about breaking down the stigma. So Ronnie talked about her son calling himself an addict, but he is a person with an addiction, not the addict. So we need to use person-first language. We need to empower families to break the silence, to take advocacy roles, to challenge the stigma, to have a choice and autonomy. The messaging of substance use disorder has been messaged as a family disorder or a family issue. I see it as a community, societal piece. We need to support our children that are affected by substance use disorder. And I've already talked about some of the ideas just previously that the community had wanted, some tacit things that they wanted, but we need to remember back to what the previous doctor said. It is a movement. It is not a final destination. And as professionals, we need to use respectful language. I know that there are community members listening. And so at any time, please feel comfortable to voice any introductions that you feel would be useful. So we know that wellness starts at birth. So bringing back the ACEs, we need, by acknowledging that we have trauma, we can work on the solution. By supporting families right from the start, we can go into the schools and focus on supporting resilience by acknowledging that almost everybody, 70% of people at least have one ACE score. So what are the things that we can do to promote resilience? And there are many things that our schools are doing to promote resilience and deal with adverse childhood experiences. I am privileged to work in a school that works on ACEs, and I know that from the many areas that they're doing, there are things that can be done to support resilience. And at least one of them is culture. And so we know from many studies that just being in the environment where our culture is apparent is a support and resilience factor. We need to focus on strengths. The strengths of our families are that they're resilient. They continue to search for help. They can, but they need more support. They need more support from the family, from the community, sorry. So what we need to do is give them the microphone and listen to them, because we need to encourage them to use their voice. And I believe the community is the solution. The community recovery piece is about understanding that substance use disorder and addictions are about brain dysregulation. It's not about bad people or bad choices. It's about brain dysregulation. And so in 2016, there was a national survey done of people in recovery from alcohol and drug use. It's called Life in Recovery from Addiction in Canada. And this picture of lives suggests that many different service providers play a role in improving the lives of individuals and their families, and that collaboration across sectors and with the community is key, which is exactly what the community members are telling us. people can and do recover from substance use. And an integral part of that solution are service providers and collaboration cross-sectorally and with the community. We need to work on breaking the silence to reduce the stigma and build connections within the communities. So this final slide is on recovery-oriented systems of care. And I think I might be done a little bit earlier, but that's okay because it opens up opportunity to have a discussion with people online. So the recovery-oriented systems of care is a resource for service providers and decision makers. It's not just about an individual, it's about everyone. And in the research that they did when coming up with this, over 95% of the people in recovery relied on their families and friends. This system involves a network of coordinated services, supports that include prevention, intervention, treatment, harm reduction, monitoring, and long-term recovery maintenance supports. And it talks about what we can do as individuals, what we can do in collaboration. And it identifies that everybody needs a different pathway in recovery. But most of all, it identifies that family has to be included in the recovery-oriented systems of care. And with that, I will end my presentation, and I thank you for the opportunity for sharing the findings that we found with Prince Albert. Thank you.